Good afternoon from San Diego, the annual meeting of the ASCRS. We're pleased to be here today with Dr. Mark Milner. Thanks a lot, Mark, for being with us today.
Well, thanks for having me. It's a pleasure.
Mark, I'd like to gain your expertise today on ocular surface disease. I know you've recently published a great algorithm that brings some new information to light on how we evaluate and treat surface disease. Can you walk us through that and
Sure.
tell us what some of the interesting findings are in that particular publication?
Absolutely. There's plenty of algorithms out there on how to treat ocular surface, which, by the way, is one of the most complex diseases we treat for many reasons. One, there are many triggers. Signs and symptoms are often disparate, and so they don't correlate. And there's so many different treatments out there and different diagnostic tests that it really is difficult to kind of put all this together. So the algorithms that really were previously out there were severity-based approaches. And it never made sense to me that you would treat mild aqueous deficiency the same way you treat mild blepharitis. So we developed an algorithm that was really more a diagnostic-based approach. We set out to do two things. One is separate dry eye into 4 key categories. And if you can separate your patients, you can have a more directed treatment, understanding that these categories often overlap. There's not one of them, but often 2 or 3 or all 4 of them. And these categories are aqueous deficiency, people who do have a decreased tear production. Their faucets turned off, they walk outside in the winter and they can't even reflexively tear. Second category is evaporative based on goblet cell or mucin deficiency. And this is a small category, but there are patients out there who have cicatricial conjunctivitis from things like Stevens-Johnson syndrome, pemphigoid, chemical injuries. And those patients are dry because they're evaporative. They may not have things like blepharitis, which when we think of evaporative, we often think about meibomian gland disease. But these patients with goblet cell deficiency are evaporative as well. Third category is blepharitis. I separate it into its own category because we understand that although you can have evaporative dry eye, you can also have inflammatory tear film from blepharitis and not be evaporative. And it is absolutely one of the most common categories we have. And then the fourth category is exposure keratopathy because exposure often gets missed. We have patients who come in with partial blink or incomplete blink or lag ophthalmos, and these patients will come to my office from doctors say, I've treated the aqueous deficiency, they're still not getting better. It's because they have a lag ophthalmos, they're still not closing. So if you can separate your patients into these 4 categories, you can actually have a much more pointed or directed treatment. As I developed this algorithm, I realized I needed a 5th category, and that's what I call the co-conspirators. The diseases that masquerade as dry eye or contribute to it, meaning that you're sitting in the chair and you're thinking, I've treated everything and nothing's getting better. Start thinking about diseases that sound like dry eye, but are not, or you're treating it and it's adding to the process. For example, allergy is a classic co-conspirator. The symptoms sound very similar, so you may be confused, but often you're treating them and they're on antihistamines, and that's making the dryness worse. Other co-conspirators would include SLK, Tygasins, mucus fishing syndrome, medicamentosa, etc. So some of these co-conspirators need to be thought about because you can often be confused and think you're dealing with a dry, but you're dealing with something else.
Well, Mark, I'm glad that you pointed out that there are several different categories, and we need to try to hone in on the specific reason why this patient may be experiencing ocular surface disease. But we also, I think, can start to combine some of the categories, right? I don't think that any one particular presentation is going to fit neatly into one of these 5 boxes. I think there's going to be probably some overlap between them. So then how does that affect how we progress through the algorithm?
So we understand very well that most patients are not just 1 or 2, but have all 3. So that's one of the reasons why when we look at treatment, if you have the first 3 categories, we start with a medication like cyclosporin or Restasis or Xiidro-Lifitegrast, one of those T-cell immunomodulators. Restasis, we know, treats the first 3 categories. It treats aqueous deficiency, it treats the goblet cell deficiency, and it treats the off-labelly, it treats the blepharitis based on the fact that we know T cells and cytokines are in the meibomian glands. So if you can treat with a T-cell immunomodulator to start, we know that you're taking care of those first 3 categories. The algorithm works by bringing them back 4 to 6 weeks later. You ask one key question of yourself. Are they 100% better in how they look and how they feel? If the answer is yes, keep them on the Restasis, and we'll see you back 6 months to a year. If the answer is no, initiate a second treatment based on those categories. So if they are 50% better and they're still aqueous deficient, now you might plug them and do everything that's in that first category. You may use lac research. You may use um, an innovative treatment like serum tears or autologous serum or a topical hormone. If they're 50% better and their Schirmers are better, but now they're significant meibomian gland dysfunction, you may add doxycycline or do a LipiFlow or do IPL or actually add one of our innovative treatments like compounded metronidazole or doxy drops for people who can't handle oral doxycycline. So then let's say you're on 2 treatments now, see them back 4 to 6 weeks later, they're 100% better. Yes, stay on the 2 treatments. No, initiate a 3rd treatment. Where severity comes into my algorithm is if they have severe, like a graft versus host patient, they're going to get potentially restasis, a steroid like Flarex, and plugs, and an antibiotic, all on the first visit. So severity plays where I might add 2 or 3 treatments. And one last thing that I want to add is one of the mistakes that we make as doctors is that we don't recognize that dry disease like glaucoma is often a multi-treatment disease. You know, we think if we initiate a treatment and they get 50% success, that it was a failure. Well, that's actually not true. Many glaucoma patients need 2 or 3 different drops. Many dry patients need 2, 3, or 4 different treatments.
Well, Mark, I'm glad that you sort of explained it in this perspective, and I want to fast forward in a way. I think that your algorithm does a beautiful job of trying to diagnose the source of the ocular surface symptoms and then going along a path to treat that source. What I want to fast forward to is 3 or 4 or 6 months later, when now you have successfully treated the signs and the symptoms of the disease, and now the patient is stable, they're doing well. I have a lot of patients that will come back in and say, look, I'm doing really well with my Restasis or my fish oil or my Xiidra or whatever treatment that they're currently doing. Do I have to keep doing it at full strength? Do I have to keep doing 2 Restasis drops a day or 2 fish oil pills a day? Can I back off a little bit? Where does the algorithm instruct us in that way?
It's a great question, and I always advise that the CEDARS algorithm talks about chronicity. And so I always advise patients that we need to be better at educating that this, like glaucoma, is often a chronic progressive disease, that if you stop these treatments, often you will get back signs and symptoms. Now, people who are, I want them on at least 6 months to a year. At a year, if they feel they're doing great, I'll often back off-labelly for the Restasis or the Xiidra down to once a day, or even as low as every other day. In my hands, anything less than that is not efficacious. But if they have signs and symptoms that recur, we bump it back up. I think the key to treating dry eye disease is to remember that most of these patients will need chronic treatment. You may be able to back off on 1 or 2 of the therapies, but ultimately, when we do, we find that their signs and symptoms come back.
Mark, I want to take this in a slightly different direction, which is to say that we know that Restasis and Xiidra are both indicated for twice-a-day treatment, but I often have patients for whom twice a day is not enough, and I might go to Restasis 3 times a day or 4 times a day, off-label, of course. But do you find a role for increasing the dosage of some of these medications?
That's really a great question. And actually, we know that there are a lot of people out there using it more than 2 times a day. And it is off-label. You need to understand that. But there are certain diseases that I feel need more than twice a day. For example, severe dry eye. So some of the graft versus host patients I find get better efficacy on 3 or 4 times a day. The others are, I find, Tigasins, which is an off-label use. We don't know why, but cyclosporin works great for Tigasins. And so in my hands, I found that they need it 4 times a day until they're quiet, and then we drop it back down to twice a day as maintenance. And then lastly, sometimes atopic or vernal. We know atopic and vernal, in addition to being an Ig-mediated response, is also a T-cell-mediated response. So in addition to using your favorite mast cell stabilizer twice a day, we'll often use Restasis or Xiidra twice a day. And many times they need it 4 times a day to put the fire out, and then we drop it to twice a day's maintenance. So yes, there are people definitely using it more than twice a day. It is off-label, but it does work. It does work at that higher dose.
Mark, this has been such a fascinating discussion for us about a great new algorithm for evaluating and treating ocular surface disease. I always appreciate your expertise. Thank you so much for sharing it with us today. And thank you for our live audience at home. We appreciate your support as well.
Thank you.